Thank you again.
Last but not the least, next is Dr. Mohsen Chisti. Dr. Chisti is an associate professor of oncology at William Beaumont School of Medicine, Oakland University. His area of focus is breast, lung, and hematological malignancies. He is a principal investigator in almost 30 plus major national and international clinical trials. He reviews manuscripts for more than 12 national and international journals. He also serves currently as the lead for Education, Research and Training Committee for Kashmir and has been very instrumental in organizing today's conference. I'm sure most of you have seen him running around with the microphone, making sure everything is on track and running smoothly, so thank you. And Dr. Chisti's talk is Exploiting the Immune System and a New Era of Cancer Treatment. With great pleasure, I invite Dr. Chisti to speak.
Thank you, Myra. You said too much, I guess.
He's very humble.
Assalamu alaikum and good afternoon, everybody. It's very difficult to stand on this podium after inventors and discoverers and all those great people that have already spoken, and especially at the, towards the end of the conference, and I'm sure everybody will be sleeping now. So, as for here, I just wanted to just like this. As for here. Okay. So I'm going to talk about exploiting the immune system for cancer treatments. It already is a segue from the basic sciences to the clinical world. Thank you. So, every day we battle against cancer. At least once every day our immune system destroys a cell that would have become a cancer if it lived. So war against cancer, then, when we traditionally talk about cancer, how it's treated, we always think about toxic chemotherapeutic agents. Maybe in the early stage you will talk about surgeries, and maybe the targeted therapy only, which was known back in the day, was radiation. We have evolved a lot. What I mean by that is we have now targeted therapies. I'm not going to focus on those. We already know, like vascular endothelial growth factor receptors. We know epidermal growth factor receptors. There are naked immunoconjugates, there are HER2, immunological agents, so on and so forth. Then there are molecules like tyrosine kinase inhibitors, or Bruton kinase inhibitors, or FLT3 inhibitors. All these molecules that go into the cell are targeted and kill the cells. And then there are immunotherapy. So I'll give you a little bit of history about immunotherapy. So we'll be talking about like interleukins, checkpoint inhibitors, CAR-T, which was already mentioned by Khalid as well. And then some vaccines, a little bit about vaccines. Immunotherapy and cancer. So you already saw, it's so interconnected. Cancer has a unique relationship to the immune system. So immune therapy aims, actually, that's why I put the topic as exploiting. It's usually like exploiting the immune system's ability to recognize and destroy the cancer cells. So broad immunotherapeutic approaches are like anti-tumor, so the immunotherapy would be against the tumor, or it could be, more like the environment, like you are looking at the host's tumor-directed immune response, or it could be the modulating the immune system by the effector cells. So therapeutic approaches, as I mentioned, we'll be talking about cytokines, checkpoint inhibitors, adoptive cell therapy, CD3-directed therapies, bispecific T-cell engagers, and monoclonal TCRs and oncolytic viruses. So how does immune therapy work against cancer? So there are two aspects of this. One aspect is the immune therapy. We already are programmed in a way that immune therapy can detect and destroy abnormal cells. So as we know, like immune cells are already found around the tumor, and we know those tumors do well if they have tumor infiltrating lymphocytes. On the other aspect, cancer cell is a highly evolved cell. It knows only to grow, to move forward. And they know how to, they can evade immune system. They know how to avoid destruction. They cause new mutations, new genetic changes, and they are less visible to the immune system. And then they also know how to turn those mechanisms off, like that would make them detect or they get killed. I want to give a little bit of background, like how this immunotherapy evolved. So immune system as a tool was actually originated in 19th century. And then there was Dr. Bush and Dr. Feldstein. They described like there was an association between an immune status and cancer. And then Dr. Eldridge in 1909 gave the concept that human body constantly generates neoplastic cells that are eradicated by the immune system. So it's not like a new concept. It just took a long time. And then Dr. Burnett said like that there's something like a cancer immunosurveillance. Then Dr. Cooley is also considered as the father of the cancer immunotherapy. In 1890s, believe it or not, he gave the concept of this spontaneous regression of the tumors because of an infection. So at that particular time, he developed like a Colles toxin, which showed some favorable responses to sarcomas. So basically, his recipe was meat, water, salt, and peptone and bacteria. So it was not like reproducible. It was not like something that you could like really bank upon. And one of the conflicts of interest was Colles' daughter. Like she said, 500 got remissions out of 1,000, which is not like which was not reported elsewhere. So Park Davis stopped its production. And also the most important thing is that the people were being treated with bacteria, and most of them, forget about cancer, they would die of an infection. So FDA pulled it out at that time. So then there's a book that shows that spontaneous regression of cancer. So there are a lot of times, immune system knows if it's smart enough, it can cause regression of the cancers, and it's documented in many case reports, case series. And then it tells us like there's something in the immune system, if it develops and it can get rid of the cancer. It took 120 years since Colles' toxin in 1890 to 2011 to develop a real immunotherapeutic agent, a checkpoint inhibitor. Why did it take so long? The problem is like we did not know enough. The T cells were discovered in 1968. Then there are different types of T cells, and now we know that it's an ever-evolving process. And then we also didn't know how they interact. We didn't know like there were checkpoints in the immune system. So this is like a little background. Like in 1986, there was interferon alpha, then interleukin therapies in 1992, then tumor modulating agents, then in 2011, ipilimumab, in 2014, pembrolizumab or Keytruda, that's very common, then working on the vaccines now. So in 2013, there was like a breakthrough of the year on the Science front cover, and then 2014, there was this special Nature edition that showed like immune checkpoint blockage is like the new grail of cancer treatment. And then the first Nobel Prize for this immune therapy that was given in 2018 to Allison and Honju, for the checkpoint inhibition, in medicine and physiology. So why monoclonal antibodies? What's the magic in them? As Dr. Eldridge mentioned, these are magic bullets. So they are identical immune cells that are all cloned, a unique, from a unique parent cell. So back in the day, it's old concept, in 1970s to 1975, Kohler and Milstein, they grew those hybridomas. So they knew these hybridomas can be grown from myeloma patients, and they can be modified by different types of genes, and if they grow together, they will produce these monoclonal antibodies. But again, monoclonal antibodies in practice came in late 2000s, and now you find these antibodies in almost all the disciplines of medicine. And now, why antibodies in cancer? Because as Dr. Shah mentioned earlier, like their tumor cells are highly abnormal and they display unusual antigens. So if you develop an antibody against those unusual antigens, they're going to work. They will at least identify them. Then if you could bind that antibody to some special radioisotope, to an immunotherapeutic agent, to a something targeted agent, they're going to work wonders. So that's kind of the way these antibodies are proving so beneficial. You can see now you have antibodies that are like they have payloads that they drop into the cells, and they are very targeted, and they are different mechanisms. They can block the targeted molecule, they can induce apoptosis, cell-mediated cytotoxicity, ADCC, so on and so forth. So antibodies, we always kind of hate this thing. Why do they have these tongue-twisting names, momomab, bizumabs, and all that? There's a science behind it, actually. So just to tell you like a couple of them, when you find tuximab, tuxi is like chimeric antibody. It's like half mouse and half human. So you will have a higher risk of developing immunological reactions in those because they are like cetuximab, rituximab, because they're half mouse, half human. Then you have recombinant antibodies like more humanized or human, like tumomabs, like you find panitumumab in this in the practice. I don't want to talk about economics. Dr. Mir already talked a lot about that. So I'll just tell you the most expensive drugs are the monoclonal antibodies. Most of them, except for some orphan drugs in practice. But if you look at as of 2022, 5 or 6 of them are the cancer drugs and antibodies. So tumor immunology. So it's a little bit of background how these immunotherapeutics work. So there are different types of cells like cytotoxic T cells, helper T cells, CD8, CD4 lymphocytes, and then there are cytokines, and there is the concept of immune surveillance. So cancer cells, as I mentioned, are advanced, so they know how to escape immune surveillance. So this is known as immunological escape. So that is how they move, survive, grow, and how they accomplish is basically they cause loss or alteration of specific antigens so that the immune cell does not detect them. Or they make the environment more immune tolerant. They kind of evade the immune system by, becoming in such a way that they are not detected. Or there could be the third and the most important, that's what we're going to focus is upregulate the expression of immune checkpoints. So immune checkpoints, that's the important concept we'll talk about a little later. So what are the therapeutic approaches? So we all know cytokines, how important they are. There are numerous downstream effects of cytokines, and higher doses of cytokines can induce complete remissions. Especially we know in kidney cancer, sometimes of stage 4 kidney cancer, we tell them, historically we know there's a interleukin 2 high dose we can give you guys, and there's a 10% chance you can go into remission, but who dares to do it? Very few. I have never done it, so maybe people have done it before me, but because we know there's a chance of dying, they could end up in ICU, they'll have cytokine storm, and there will be other side effects of cytokines. However, it's proven that there are 10% of the patients of metastatic renal cells that they can get cured. And then you have other immune-mediated processes, so immune modulator therapy. So they also work through cytokines, but the mechanism is diverse. So for instance, you have this multiple myeloma drug, Revlimid or lenalidomide, or you have all of the drugs, so pomalidomide. So basically the mechanism is the same. You modulate the immune system, and they are able to kill the particular types of cells, like myeloma cells. Then we know the interferon 2 alpha in melanoma. So in stage 3 melanomas, you could give them interferon as an adjuvant treatment to avoid melanoma recurrence. And then other important one that we cannot forget is the BCG. We all got those BCG back in the day. But as an immunological agent, it is used by our urological colleagues by injecting it to the bladder. So, and it causes a robust immunological response and avoids a recurrence of the cancer, proven by a lot of studies. Now we come to the immune checkpoint inhibition, and that is, right now it's used in almost everything. So to give a background, tumor produces all these, these tumor antigens. They are taken up by antigen-presenting cells like dendritic cells, and they present this to the T cells, and then resting T cell becomes an activated T cell, and it can be trained to go and kill the cancer cell. So nature has made a mechanism to identify a cell and kill it. However, cancer cells are smart cells. So tumor cells that express PD-L1 on their surface attach this PD-L1 to the PD-1 on the surface of the T cells, and due to this combination, it makes this T cell impotent. It doesn't work. It doesn't kill the cancer anymore. So by dint of that, the cancer cell is able to evade the immune system and grow and flourish in the system. So that was the breakthrough discovery, that if you block this blocking thing, if you block this feedback mechanism, if you remove these brakes off the immune system, what will happen? And we saw tremendous responses in cancer. So basically what PD-L1 receptor, it inhibits immune regulatory pathways, and then it expresses preferentially by T cells with prolonged antigen exposure, and it negatively regulates effector phase of the T cell responses. So just comparison, like these are like the brakes and you're pulling the brakes off the immune system. There are consequences to it as well, and we'll talk about that as well. So basically in effector phase, where can you use this checkpoint inhibitor? You can use it when there is an interaction between an antigen presenting cell and the T cell, because it's trying to make the T cell learn to catch that cancer. However, because of the B7 and CTLA4, this mechanism doesn't go further. It's a feedback. So if you block the CTLA4 by ipilimumab, then you break this effector phase. And then you have the other part, this was the priming phase. Then you have the effector phase where the T cell interacts with the cancer cell by PD1 and PDL1. PDL1 is the antigen on the cancer cell. So because of this, then T cell cannot kill the cancer cell. So now if you block it by ipilimumab or nivolumab, then you achieve that thing that you remove the brakes off the immune system and the T cells continue to kill the cancer cells. And I don't want to go into the survival data, and there's so much, there's a ton of it, like in every cancer now. But the bottom line is it has improved survival in almost all the cancers. In fact, now they are looking at even PDL1 low, not to talk about PDL1 high cancers. So essentially, if we have to talk as an oncologist, like where does it definitely work? There's this mechanism known as mismatch repair or defective mismatch or microsatellite instability. So there was something in the news not that long ago where they said like 100% responses in the rectal cancers. There was in the media, for, every patient will come to you and ask, oh, can I have this, So those are the Lynch syndrome or the defective mismatch repair, or they have the microsatellite instability where immunotherapy has worked wonders. And the other patients are like the PDA1 or PDL1 high, or the third category would be the tumor mutation burden. So you'll see in these reports they have tumor mutation burden. The more the mutations, the better the responses. However, after doing all this, you may, like happens in once in a while, you talk to the patient, you're free of cancer, but you see that patient dying because of these adverse effects. I recently remember a patient who was 55-year-old, free of cancer, but ended up on the ventilator, had pneumonitis, couldn't save her. So there's a new spectrum of these adverse effects we need to know and be ready to act, and because many a times we don't always see them as oncologists because they might be in ER, they might be in a primary care office, they might be in some other specialties. So it can cause, I tell my patients, aniitis like encephalitis, hypophysitis, aseptic meningitis, pneumonitis. But the most common are like the thyroid, thyroid is very common, new onset diabetes is common, hepatitis is common, colitis is common. There are case reports of everything actually. But we need to be aware, we need to be ready, and we need to know what we need to do, how we have to manage them. So basically, steroids are the most important drugs that we need to use in them. If they are early, grade 1, don't hesitate to start steroids as soon as possible. That might help in getting it much worse. And then there are different recommendations of steroid refractory patients. How do we treat them? So there are agents like infliximab, vedolizumab that are very beneficial. Acutely, you can give them IVIG. And if they are like cases like myasthenia gravis or something, you treat them as myasthenia gravis. Even sometimes you might have to do the pheresis as well. And then it could be like, sometimes they could have encephalitis, and they could have, as I mentioned, myasthenia gravis. Rituximab also helps in those patients. And in nephritis or myocarditis, we sometimes use mycophenolate mofetil as well. All those immunological agents that they're actually now we have NCCN guidelines for these immune-related adverse effects, how to act in different types of immune adverse effects. And then same thing, we talked about the colitis and encephalitis. So this another checkpoint inhibitor which is gaining importance these days. It's a LAG3. It's a lymphocyte activation gene. So basically these are expressed by B cells, some T cells, NK cells, tumor infiltrating lymphocytes. So basically it enhances the T regulatory activity by binding to the histocompatibility complex, MHC class 2. So right now there's only one that is being used in clinical practice. It's relatlimab. It's a LAG3 blocking antibody which is used with PD-L1 in melanomas, but it's something new coming up. So immune checkpoint inhibitors are approved in almost all the cancers. As I mentioned, we have some parameters to see which one, where to use which one. They could be against the CTLA4, they could be against PD-1, they could be against PD-L1. But essentially you are removing brakes off the immune system. And sometimes, as 80% do well, but 20% they can have adverse immune effects like the autoimmune adverse effects as we talked about. So other potential targets of the immune inhibition are the BTLA or B and T cell lymphocyte attenuators. Other is VISTA, V domain, IG suppressor, and there's TIM3, T cell immunoglobulin and mucin domain 3, and there's CD47. So it's an ever evolving science. It's going to go further, and things will be very different. And then now to talk about stem cell, I'm not even touching that. I can't even do it justice to that. So then adoptive cell therapies, there are three major approaches. One is CAR T, another is TCR T cells, and there is tumor infiltrating lymphocytes. So CAR T, Dr. Shah was mentioning about this. Basically, you are creating a trained antigen that can have multiple ways to work, both antigen binding as well as T cell activating function in the same cell, same domain, so they are able to do multiple tasks at the same time. So these are designed and they are basically right now in use in many hematological malignancies, especially lymphoma, CLL, diffuse large B-cell lymphoma, like Yescarta and other drugs. So I know Dr. Shah mentioned about this, I'll just briefly mention. You basically get the T cells out, you train them in the lab by T cell activation and transduction with the retroviruses. Then you grow these cells basically, and they have these chimeric T cells. Then you give some low dose of chemotherapy to the patient, remove the lymphocytes, put these trained T cells back, and then there are excellent responses to the tumor, especially a lot of it has published now and they are used in clinical practice. The other one I wanted to talk about, the superior cell T. This has been there since 2005, but the challenge is always that you have to get these cells out from the prostate cancer patients, then you have to train them in the lab. It takes 6 to 8 weeks, they're metastatic, there's a lot of money involved, insurances don't approve it easily, but it's one of the things that are available to us. Regarding tumor infiltrating lymphocytes, so basically the concept is again the same, exploiting the immune system. So we know the tumors that respond well attract lymphocytes, and they are able to, these lymphocytes are able to deal with the cancer, contain it. So in patients that have this tumor infiltrating lymphocytes, you basically grow them outside the lab and then put them back. So the problem is you need fresh resected tumor. You also have to grow in the lab. It's like thousands and thousands of dollars, and then it's a huge challenge. It's a thing that is available but not used that much. Then there's CD-directed therapy. This is something new and this is upcoming, and it's only one agent right now. It's the blinatumomab. Basically, these are bispecific T cell engagers, or also known as BiTEs, different from the BiTEs of computer. What they do is they are linkers between the T cells and the specific target antigen. So basically, as the name suggests, they are bispecific engagers. So they attach to the tumor cell and attach to the T cell and help in better immune response and killing of the cells. And then cancer vaccines, I'm not going to talk too much about it because this is not much in practice yet. We know about the preventative vaccines already that can prevent cancers, but what we talk about therapeutically are the vaccines that can help to fight cancer. So basically, as I mentioned, dendritic cell vaccines like superior cell T, then there are antigen vaccines, anti-idiotype vaccines, and DNA vaccines, autologous versus allogenic vaccines. And oncolytic viruses. So this is the only drug right now that we have is TVAC. It's lamotrigine leperparavir. It's a herpes simplex 1 virus vector that helps in kind of putting this antigen into the cell and then growth of that in vivo, like actively in the body. So that's the only virus that is actually available right now. So I'll be happy to answer any questions. I hope you enjoyed the talk.
Thank you, Wilson. Again, any questions? We can take a question.
Just one, from a radiological perspective, I'm saying that these checkpoint inhibitors, in brain tumors, we knew pseudoprogression, pseudo-response.
Right.
But now with this coming to the fore, I'm seeing this a lot in spine. I'm seeing this a lot in extraCNS tumors also. So radiology as a whole has to keep pace with this.
Right.
And if advanced oncological imaging techniques are not being used by hospitals, there's a potential for a lot of mistakes being made for such advanced stage 4 disease patients.
It is a challenge, as I mentioned, there are like MR SPECT or acetylcholine and all. Still then, when there's an immunological adverse effect in the brain, it's very challenging, it's very difficult, because the other aspect of it is also that if you're talking essentially of the brain tumors like GBMs, there's not a whole lot of penetration of like pembrolizumab through the blood-brain barrier. So that's why it's not that used that much, even though when we check those tumors and we see they are PD-L1 high, it's not that effective.
The reason I'm saying because we get referred a lot of patients from outside hospitals
Right.
where therapy has been stopped on these patients.
Correct.
And when we do our advanced oncological imaging, we see actually sort of progression.
Right.
So like we would continue on these checkpoint inhibitors.
So are you talking like the difference between like inflammation due to a checkpoint inhibitor versus the progression? Yeah, it's a challenge. I don't think there's a single test.
Hypophysitis,
Yeah.
pituitary.
Yeah.
That can happen as a complication. It's not tumor that is
Right.
creating.
Yeah. Yeah, it's a challenge.
Yeah.
It was an excellent talk. It's hard, I have a complicated question. It's hard for me to accept, but as a surgeon, that we are truly frequent the question I have is, can we use immunotherapy to target gene mutations and prevent cancers, especially with
So to prevent the gene mutations. So the concept will go more towards like a targeted therapy rather than an immune therapy, because immune therapy is exploiting the immune system, not the target, like a target that you already have. The target would be more like a key, lock and a key. You had the right key for the right lock and you use that as a target. So you're talking about like a blend that we have now, bispecifics and all, where you have a target as well as you're using an immune response. That's the concept of blinatumomab. So where you have a target as well as you're using the immune system, you're activating a T cell as well. But yeah, that's different than the checkpoint inhibitors, where checkpoint inhibitors basically train your own T cells to fight cancer in a very different manner.
Awesome. Great talk, great overview. Some patients do not respond to anti-PD-1 or
Yes.
anti-PD-L1, but then the patients that do respond also develop or acquire resistance.
Right.
So what is the way forward for those patients?
As I mentioned, so genetically, cancer cells are more evolved. Evolutionarily, they are more evolved. They know how to survive in adversity. So they always come up with different mechanisms of resistance. What we see that's the reason we do re-biopsies after the tumor progression. And we see the PD-L1 levels are dropped. Like, if the PD-L1 was high when the patient was responding, you do a repeat biopsy. PD-L1 level is lower now. So something has changed in the cancer cell that is now, making it more viable and, more progressive. So it's new mutations, new changes. Yes, Dr. Khan.
It's not a question because I don't know what to ask. I want to thank Bilal, Samia, Arif for bringing all of you here. My backyard, I have 10 minutes and here I am getting, I feel like if I went to sleep, came after many years, and it's just fascinating to see what's happening at the cellular level and how many advances there are. And I want to compliment the speakers for brilliant presentations, particularly since some of them graduated at Nassau County Medical Center, and it's so nice to see you guys reaching higher and higher. And that's what our teacher always looks for. That the next generation will do better than the current generation. So my compliments and thank you, and tonight